cherished. All right, guys, we have Ahmed here. He is one of our former fellows. Ahmed, are you 2 years out now?
Yeah, I'm a year and a half. Yeah,
Year and a half. Yep.
so
So
fresh.
he is an overachiever. So he's internal med trained and then did a rheumatology fellowship and then decided he hadn't had enough. So he came back to do sports with us. And he's working right down the street at Cleveland Clinic now, doing a combo of rheumatology and sports medicine. So when he was a fellow, we all learned a lot of rheumatology from him. And certainly, I thought this would be an invaluable topic because there's so much overlap and stuff that we probably don't even think about that we should be thinking about when we see sports patients. So I invited him to join us today, and he was kind enough to donate a little bit of his time. So I will let him take over. I'm gonna, and at the end, we should have some time for questions. Okay. Thanks for joining us, Ahmed. We appreciate it.
No problem. Thank you, Sue, for inviting me. It's that's a very warm welcome. I appreciate it. I still will stick by saying that my sports fellowship was my favorite year of training. I loved my room fellowship, but the most fun I had was my year at sports medicine. And so I do agree. I think there is a lot of overlap between rheumatology and sports medicine. I think they're two sides of the same coin. I think the most common things that you see in rheumatology typically are MSK related. But there's a lot of features of it that typically mimic some of the things we see in sports medicine. So this is kind of just a little bit of an overview of some of the things to think about. Not necessarily going to teach you how to be a rheumatologist in this talk, but I do want you to kind of at least appreciate and recognize some of the things you're probably going to see in your practice. So this is rheumatology for the sports medicine physician. No disclosures. I unfortunately have no financial relationships with anybody, no conflicts of interest to resolve. And some of the objectives we're going to talk about, we're really going to focus a lot on arthritis, some of the differentiating features of inflammatory and degenerative arthritis. We're going to touch base on a couple of rheumatic conditions as well. We'll talk about some physical exam findings, labs, imaging of arthritis, review some of the treatment plans. And if we're just going to kind of break it down by topic, we are going to again talk about mostly arthritis and some of the rheumatic diseases, but we're going to spend a little bit of time also on therapeutic use exemption for the rheumatic patient, and then with a couple of slides on vaccinations for these patients who are typically on immunosuppressive therapies. So to understand inflammation in general, you kind of have to think about the immune system. And you know, talking about the immune system, that could be a whole talk in and of itself, but what you should know is that there are primarily two different parts of the immune system, the innate and the adaptive immune system. The innate immune system is very primitive, typically very, very fast acting. It recognizes patterns from pathogens and it goes in and attacks right away with neutrophils and macrophages and dendritic cells. The adaptive immunity is much more slow growing. It's much more sophisticated. You think about when you develop like memory T cells or killer T cells, or producing antibodies. This is more of the adaptive immunity. And if there's a problem with either one of these things, with the innate immune system, that usually develops auto-inflammatory diseases. Things that you think about are like familial Mediterranean fevers, a lot of like periodic fever syndromes. Whereas the adaptive immunity, if there's a dysfunction there, you develop an autoimmune condition or diseases where there's a lot of auto antibodies that have a lack of tolerance to self and attack the body itself. So now we'll go into a bit of arthritis. There's over 100 different types of arthritis, but you could kind of capture 90 to 95% of these with both osteoarthritis and rheumatoid arthritis. Anywhere between a fifth and a quarter of the population will be diagnosed with arthritis at some point. Especially osteoarthritis. If you're seeing any adult patients at all, you're going to see osteoarthritis every single day of your practice. And typically we're seeing this in patients who are getting older, patients who are heavier, patients who had a previous injury, even in their youth, can go on to develop arthritis in those areas. Those with a lot of chronic disease and a lot of comorbidities. And the reason being is with those usually leads to a more sedentary lifestyle. And then when they go and try to use their joints, they put a lot of unnecessary stress on them. With rheumatoid arthritis, much less common, only affects about 1% of the population above the age of 35, but is the second most common type of arthritis and the most common type of autoimmune disease that we find. When we think of arthritis, we should not think of just the physical burden of it, but also the economic burden. About 1% of the entire U.S. gross domestic product is spent on arthritis in some way, whether it's treating it or in lost wages. So it is a really big deal. It is something that really impacts the patient's life, but not just the patient itself, but just society in general. So if we talk about arthritis, we can kind of split it into a few different types: degenerative and inflammatory. Degenerative is what we typically think of as osteoarthritis. Inflammatory can be split into a few other types of causes. We think of like classic connective tissue diseases like lupus and Sjogren's, where the primary feature is not necessarily musculoskeletal, but it can be a feature of it. And then some of the other more prominent features or diseases that have arthritis are rheumatoid arthritis, which can be split into either seronegative or seropositive. What that means is that the antibody associated with that disease is either positive or negative. For rheumatoid arthritis, we have rheumatoid factor and CCP. So if either of those are positive, you call it seropositive. If both are negative, but your suspicion is still high, you can call it seronegative rheumatoid arthritis. For crystal arthropathies, there's a lot of different kinds actually, but the pathologic ones that we typically see in real life are gout and pseudogout. And then for the seronegative spondyloarthropathy, this is like kind of an umbrella term that we see that encompasses a lot of different diseases. And we'll go into each one of those briefly throughout the talk. And that includes angst-pon, psoriatic arthritis, reactive arthritis, and inflammatory bowel disease related. Talking about osteoarthritis first, this is typically an issue with the hyaline cartilage becoming more unstable, whether this is friction-based from wear and tear, whether this is maximum loading from a heavier patient who and poor posture or poor framing of the joint, or direct trauma from a previous injury. What happens is that the collagen actually starts to degrade. The body starts to react to this degradation by causing a pro-inflammatory response. Metalloproteinases come in and kind of start to eat away the cartilage, and then there's bone exposure. When that bone is exposed, that's when the damage really starts. So why does this happen? We're not really sure. We think that sometimes it could be congenital. You might have like a primary osteoarthritis. We say that we inherit our anatomy from our parents. So if your dad has a low back problem, there's a good chance you might too, especially if you're in the same sort of environment and doing the same kind of work. We do know that there could be a hormonal component. There are some patients who are on hormone replacement therapy or on therapy, some sort of chemotherapy, who go on to develop accelerated osteoarthritis. Like I said, previous injury will increase the risk. And then sometimes we just don't know why it happens. We do know it happens as we get older and as we get heavier. And typically the most common areas involved are the weight-bearing areas, the hips and the knees, as well as any areas with repetitive motion or pinch or grip, such as the hands. We think of like the PIP and DIP joints, but the thumb is probably the most commonly involved. Clinical symptoms, typically the more you use that area, the worse it feels. The more you rest, the better it feels. You can develop a little bit of morning stiffness, but typically it goes away right away. Should not last more than an hour. Usually shouldn't be any erythema or swelling or synovitis that you typically see in inflammatory arthritis, but you can develop some effusions, especially like in the knee. You can develop bony enlargement. Part of it is because you're developing bone spurs from that repetitive rubbing, but also when you have a lot of muscle wasting around the joint and patients become more sedentary, you can almost get like a pseudo bony enlargement as well. From an imaging perspective, we're looking at joint space narrowing. We're looking at bone spur or osteophyte formation. The integrity of the bone actually starts to wear away. You can develop sclerosis or just kind of jagged irregularities. And then you can actually develop like subchondral cysts or geodes. From a lab perspective, we don't check any labs to diagnose, treat, or manage osteoarthritis. From a radiographic perspective, this is actually not that bad of an X-ray, but you can see if you look at towards the PIP joints, you can see some joint space narrowing, some subchondral cyst formation, some bone spurs as well along the PIPs of several of these digits, a little bit of a cyst here as well. And you can see a little bit of joint space narrowing along the DIP. But you notice that the MCPs are relatively unharmed here. A little bit of osteoarthritis along the carpal bones as well. This is a patient I have who had a remote injury of her hip many years ago, and then went on to develop arthritis in her right hip. And this is a good picture because it kind of shows the difference between a fairly, I mean, there's a little bit of arthritis in this hip, but a fairly unremarkable left hip versus the damage being done by bone-on-bone osteoarthritis of this hip, with a lot of subchondral cysts, a lot of osteoarthritis, a lot of bone spurs, and really, this patient really even can't move this hip in any direction at all. Looking at treatments, typically we treat conservatively with Tylenol or NSAIDs. You can use neuropathic medications such as gabapentin. Physical therapy in occupational therapy are very important in terms of maintaining the strength around the joint, which is always important in trying to prevent it from progressing. You can do injections, corticosteroids, physical supplementation, PRP. All these things have a risk involved. The literature doesn't really support any of these things, to be honest, for long-term management of osteoarthritis. But anecdotally, I know that we all do it, and our patients really benefit from it, at least from a functional standpoint. So, pick and choose what works for you. And then last resort is a surgical consult for replacement. Now, the next thing I want to talk about is an athlete who named Spencer O'Brien. She's a very decorated snowboarder from Canada. She's a 2013 snowboard world champion. She's a 5 times X Games medalist, including a 3 times bronze medalist and a silver medalist. But the important thing for this talk is that she was actually diagnosed with rheumatoid arthritis in 2015 at age 25. And then, if you can see, she actually went on to win the gold medal at the X Games after this diagnosis. And so you can still do really, really well despite these diagnoses. The rheumatoid arthritis, most common autoimmune symmetric inflammatory polyarticular arthritis. So typically you're going to have features that affect both sides. It does encompass about 20% of all arthritis, or 1% of the population. It is primarily a joint-driven disease process. That being said, you can have other manifestations as well. And by the time someone develops rheumatoid arthritis, typically they've actually had this for quite some time. They usually have the serologic pattern of positive rheumatoid factor CCP for many, many years. They're just kind of in this like quiet, quiescent sort of scene. And then one day they just start developing some of these manifestations. From an etiology standpoint, we do think that there is a genetic and environmental component that increases the risk of developing this. We see this sometimes in twins. If one twin has it, there's a good chance that another twin may have it as well. From an environmental standpoint, you can actually develop autoantibodies from some of the things that you can do in your everyday life. If you smoke, if you don't take care of your teeth, if you have a low vitamin D, these are all things that can induce autoimmunity. As with most autoimmune conditions, typically affects females more than males. We're not really sure why this is the case. It could be that women have 2 X chromosomes. X chromosomes are more prone to mutation because they're larger. It could be that women go through more hormonal transitional periods throughout their lifetime. Men really just go through puberty, and then really the numbers start to taper off slowly over time. Women go through puberty, potentially pregnancy and childbirth, and postpartum, potentially multiple times, and then menopause. And so all of those fluctuations in hormones can induce autoimmunity. The real answer is we really don't know why women get it more than men. Typically, you see it in middle-aged adults, slightly older males, but you can get it younger too, as you saw in Spencer O'Brien. And it's driven primarily by a pro-inflammatory response. So like I said, very symmetric type of picture, loves small joints. You're looking at the MCPs and the PIPs, the wrists, but you can involve some other joints such as the knees and the shoulders as well. You can develop it anywhere from an alloarticular to polyarticular distribution. So anywhere between 2 and 4 joints for alloarticular, 5 or more for polyarticular. And these are patients who typically have more morning stiffness that lasts over an hour, which tells us that there could be an inflammatory component to this. You see a pannus formation or kind of a hypertrophy of the synovium. This destroys actually the synovium and eventually can actually start to wear away the bone itself, which is different compared to degenerative osteoarthritis. Degeneration is different than erosive disease. Doesn't just wear away the bone though, you can actually start to wear away some of the tendons involved in the hands as well. So you can develop boutonniere or swan neck deformities because the flexor and extensor tendons in the hands get worn away. That being said, if you develop more of an asymmetric picture, kind of a migratory picture, you get DIP involvement, you get low back symptoms, typically not associated with RA, you should be thinking of a different diagnosis. So looking at it from this just compares a healthy joint to a rheumatoid joint. And the big thing takeaway here is that the synovium is very, very swollen. It attracts a lot of the immune system to come in and try to clean it up. And it does so with a lot of collateral damage. It wears away the cartilage. So it causes some bony destruction underneath the cartilage as well, but it actually will actually start to infiltrate the bone and cause erosive changes along the bone, even outside of the joint itself, and can induce osteoporosis much earlier in these patients' lives. From a joint distribution, like I said, much more small joint involvement, MCPs, PIPs, but it can really affect a lot of different areas. It can affect even the cervical spine to some degree, but typically you should be looking more at small joint than medium or large joint. When we look at it clinically here, in A up here, you can see both swan neck deformities here with an extensor deformity of the PIP and a flexor deformity of the DIP, and the opposite here with this boutonniere deformity. If you look here, you can see kind of this ulnar drift that you can typically see in patients who are untreated with RA. And what happens is the radial collateral ligaments become affected as well. The ulnars not as much, and so you get unopposed ulnar drift. And this compares both a clinical picture with a radiograph, and as you can see, you have these ulnar deformity or this ulnar drift with these deformities. And if you look at the hand here, just complete destruction of the MCPs and the wrists. This is not a patient with RA. This is actually a patient with J or juvenile idiopathic arthritis, which can precede some of our autoimmune conditions. The reason why I put this is just to kind of show the difference between an infused knee and a regular knee. It is quite impressive. It can be a little bit more difficult in RA since both knees typically would be swollen. But if you're having a patient with a lot of buckling of the knee, a lot of warmth around the knee, and it looks more like what you see here of the right knee, that is more typical of RA. And when you compare it to OA in terms of distribution, you see a lot more small joint involvement of the hands and feet in RA. You see a lot more of like weight bearing issues with OA, and specifically, I think you see a lot more osteoarthritis of the spine itself, not nearly as much in RA. From a lab perspective, you're looking at elevated inflammatory markers with an ESR to CRP. From a CBC standpoint, you might have a little bit of anemia. You can also have a thrombocytosis or elevated platelets. High platelets in acute inflammation can kind of be treated like an ESR or CRP. It's a kind of an acute phase reactant. Chemistries are typically okay. You might have like either a low or normal albumin, but otherwise the chemistries are fine. Rheumatoid factor and CCP are the antibodies associated, and they can be positive or negative. And then an ANA can sometimes be positive in these patients as well. An ANA is not always just, hey, this is lupus. You can see ANA in a lot of different autoimmune conditions as well. From a synovial fluid, what you'll typically do is you'll drain fluid, you'll look at the cell count, you look for crystals, you look for gram stain and culture, and you'll take a look at what the actual fluid looks like. For inflammatory disease, what you'll see is that the patients will typically have more of a yellow, cloudy type of fluid. It typically, if you were to send it to a lab, you'll see that the white cells will be above 2,000, can be all the way up to 50 or 100,000. So it kind of lives in that area between normal synovial fluid, which would be yellow and clear with really no white cells at all, and then a septic joint where you'd have a very, very like either purulent or a very cloudy fluid with like 50, 100, 200,000 white cells. And typically in a septic joint, you'll also have a positive culture or gram stain. On imaging, like I said, you'll have erosions, you'll develop periarticular osteopenia that can develop into osteoporosis. An important thing to think about in these RA patients is atlantoaxial instability, which is important for our athletes. And usually when these patients are seen in our clinic, we do like to regularly get x-rays because x-rays changes usually take about at least 3 months to show. If you have a patient with x-rays that are not really that useful for you, or it's clinically ambiguous, you can get an MRI, ultrasound that can tell you if there's a lot of inflammation or of either the joint or the tenosynovium. Taking a look at x-rays here, you can see some bony erosion here along the hand. If you look at going from B to C to D, D is actually okay. These hand x-rays are actually fairly normal for the most part. And as you go to C, this is progression of the disease. You start to see some erosions along the MCPs here and here, as well as kind of like the entire x-ray is just becoming a little bit lighter. You're developing a little bit of osteopenia along the hands as well. And then this is like end stage where you have complete destruction of the MCPs, complete destruction of the carpal bones. So this is clearly someone who was never actually treated for rheumatoid arthritis. And looking at it from an ultrasonic perspective, this is looking at an MCP with A being a completely normal, joint space is okay. You don't see a lot of swelling here. The tendon itself looks intact. And you go down to B, and now you have some heterogeneity along the tendon and a little bit of swelling here, a little bit of fluid in the joint space itself. If you look to C and you turn on color, you can see swelling along the synovium and tenosynovium. And then in D and E, you're looking at a little bit of an erosive change here that you can sometimes pick up along the bone with inflammation when you turn on color. This is a patient that I see who developed rheumatoid arthritis at a very, very young age. Unfortunately, we didn't have a lot of our medications that we do now, so she was never properly treated. And you can see just again, the joint space between the hands are completely, between the MCPs completely gone. The carpal bones kind of collapsed along itself. And really, this is a patient who really can't even make a fist anymore, at least on the right side. Looking at it from the cervical spine, this is important because atlantal axial instability usually is caused because of a pannus formation along C1 and C2. And so what happens is upon flexion, you have this anterior subluxation of C1 over C2. This is really important in athletes because those who are engaged in more like contact sports or collision sports are very high risk for developing some major issues, neurologic issues if they are hit, such as developing myelopathy, developing quadriplegia, and sometimes even worse. From a diagnostic perspective, we do have a definitive diagnostic criteria that we use from 2010. There's a joint involvement domain, a serologic domain, ESR, CRP, or QPase reacting domain, and the duration domain. And as you can see, joint involvement by far carries the most weight in this. So if you have a lot of small joint involvement, that can already get you close to the diagnosis. From a treatment perspective, from a rheumatologic perspective, we have a lot of medications that we can use now for rheumatoid arthritis. From a sports medicine perspective, NSAIDs and prednisone are usually going to be okay to use in the acute setting until they're seen by a rheumatologist. From an exercise perspective, we like to do a lot of low impact exercises to minimize pain, a lot of aerobic activity to maximize cardiovascular health. And this is important because those with rheumatic disease go on to develop cardiovascular disease much later in their life, but earlier than someone without that disease. So we want to make sure their heart stays strong. Like I said before, if they have atlantal axial instability, C1 over C2, avoid contact sports, combat sports, collision sports, because this is very, very high risk for them. And then we kind of base the recommendation based on how they're doing from an RA standpoint. If they have high disease activity, we typically say only range of motion exercises, minimal weight bearing, but really you could get away with really just kind of pulling them aside and not having them compete at all until their disease is a little bit more controlled. Mild to moderate, usually low impact exercises, swimming is really helpful. And then if they're in remission, we really have no restriction at all. So the next topic we're going to talk about, a few professional athletes here. Franklin Gutierrez, who is a center field and right field for the Indians, and he's already retired. What is he, Phil Mickelson, and George St. Pierre all have in common? While they all have diseases that are considered part of the seronegative spondyloarthropathies, with Franklin Gutierrez having ankylosing spondylitis. Phil Mickelson, very well known to have psoriatic arthritis, did very well on etanercept or Enbrel, and is actually a spokesperson for that medication now. And then George St. Pierre, considered one of the best UFC MMA fighters in the world, actually had to step away from the sport for quite some time because he developed ulcerative colitis. And so again, this is an umbrella term that we use to encompass a lot of these diseases. And the main hallmark feature is that the rheumatoid factor is negative. You have Angst-Bond, non-radiographic Angst-Bond, psoriatic arthritis, reactive arthritis, and IBD related. From the features that we see here, typically, like I said, negative rheumatoid factor, you can have potentially a positive HLA-B27 antigen in these patients. It's not required, but if it is positive, it makes us think much more that they may have this. The most prominent feature of this class of diseases is low back pain, inflammatory back pain. Okay, whether you can have inflammation of the sacroiliac joint or of the lumbar spine. And then some of the other extra articular manifestations, you can have enthesitis, predominantly along the Achilles, along the epicondyles, or along the greater trochanters. You can have ocular disease like uveitis. You can develop cutaneous disease like psoriasis, or you can have someone who with a lot of chronic cystitis or from an infection standpoint. So talking about ankylosing spondylitis, these are patients, typically patients in their 20s. You can see them in their teens, 20s, 30s. So anyone above 45 is not that typical to see. This is one of the few diseases where men are affected a little bit more than women. And like I said, typical low back pain, you can develop alternating sort of buttock pain, enthesitis. And inflammatory back pain is different than mechanical back pain in the sense that it's usually worse, a lot worse in the morning, and they'll use a lot worse with rest. When you get these patients moving, their back pain slowly goes away. This pain, because when they're sleeping at night, they're not moving around. They can actually wake up because of this pain. And morning stiffness typically lasts more than 30 minutes. You can also kind of an extra-articular manifestation is developing visual symptoms like anterior uveitis, which is more predominant in XSPON than some of the other seronegatives. When we test these patients in the clinic, what we do is we really test their mobility. We do a modified Chauver's test where we actually take a piece of tape, we measure it at the level of the PSIS, and we have them bend forward. If they move more than 5 centimeters, we know that there's still some good range of motion of their low back, and that's a negative test. If they're really, really restricted, then we know that that's a positive test. We also measure their chest expansion. If we have them take as big a deep breath as they can, and if they cannot extend or expand their chest more than 2.5 centimeters, we know that there's some restriction there as well. And we also do an occiput to wall test. We have them stand up against the wall with their heel against the wall, and their shoulder blades against the wall. And if they can't put their occiput against the wall, we know that there's also some forward flexion deformity or stiffness that account for it as well. From a lab perspective, typically negative ANA and rheumatoid factor. You may have a positive HLA-B27, you may not. And those who have XSPON, 90% of white patients with XSPON have an HLA-B27 positive, 50 to 80% of non-white patients have it. But you can find this in about 6% of the population, even if they don't have XSPON at all. From a radiographic perspective, we see a lot of sclerosis. We see a lot of squaring of the vertebrae. And then if the inflammation goes on for a really long time, the bone can actually start to fuse together, and it can actually cause the sacroiliac joints to fuse, or the lumbar spine to actually to kind of merge together and develop what we call a bamboo spine. If you're not able to tell if the patient has any inflammatory changes yet, or still really early in the course, you can always get an MRI, and the MRI could show some edematous changes along the sacroiliac joint or along the vertebra of the lumbar spine. So this is typically what we see in A. We see that squaring of the vertebral body, which is like a precursor to developing that bamboo spine. And then the other two images, you'll see from a lateral and AP view that the spine is kind of completely fused together, and it becomes really difficult for these patients to kind of move in any direction, whether they're side bending or they're flexing. This is a patient that I had. This is actually a patient who initially was seen by Dr. Salata for hip pain, and as you can see, it has a bit of protrusio acetabulae here, but was also having low back pain, and caught that she had some sclerotic changes along her SI joint. So she was referred to a rheumatologist. She just happened to work her way into my clinic, and when we got an MRI of her low back, you could see some sclerotic changes and so edematous changes along T1 and STIR. She was diagnosed with ankylosing spondylitis, and she was treated. I'm actually in the process of getting a repeat MRI because she has clinically improved considerably. So I'm working on getting that at the moment. And another disease that we see in the seronegatives is psoriatic arthritis. Typically, a lot of the key features, psoriatic plaques or good fit psoriasis. As opposed to rheumatoid arthritis, which is very symmetric, you typically see more of an asymmetric inflammatory arthritis. And as opposed to ankylosing spondylitis, where the sacroiliac joints are both involved, typically in psoriatic arthritis, only one side is usually involved. You can develop dactylitis or sausage digit, and you can develop nail changes like onycholysis, pitting, or hyperkeratosis. And we take a look at some of the images here. You can see a very, very prominent swelling of the third digit here. This is what we call dactylitis. You can see some plaque formation. This is actually a pretty severe case, but it doesn't have to be the severe. Typically find it more on the extensor surfaces. You're looking at the extensor forearms, you're looking at the elbows, and looking at the knees, but you can develop it on the scalp, you can develop it behind the ears. So having that it can be a precursor to developing psoriatic arthritis. And then when you start seeing nail changes, then you start to think that, hey, maybe this, if they did have psoriasis, it may have transformed to psoriatic arthritis. And typically we see like nail pitting. It's almost like someone took a pen and started just poking holes in that nail. You see more like hyperkeratosis, and you can see like onycholysis or sort of like these little oil spots as well. Very, very specific finding for psoriasis and psoriatic arthritis. Looking at it from a radiographic perspective, you can see some asymmetric sacroiliac sclerosis here compared to this side. We look at bony erosions here as well, like periarticular erosions along here, here, and here. So kind of a migratory distribution. It's not completely symmetrical across the board. And then kind of end stage, would you see this? It's what we call like, and this is kind of like a buzz board term, but it's sort of the pencil and cup deformity here, which you typically see more in the DIPs of the hands and feet. If you're looking to sort of to diagnose, we don't have a diagnostic criteria. We use a classification criteria, but essentially all you really need is evidence of psoriasis, a negative rheumatoid factor, and then either some sort of like radiographic change or dactylitis or nail change. Okay. As you can see, this is not perfect. If you have someone who has active psoriasis and a negative rheumatoid factor, that technically says that you have psoriatic arthritis. But if you have no arthritic symptoms, we don't call it that. So not a perfect system, but it can lead you kind of in the right direction. Reactive arthritis, we're talking about patients who are post-infectious. Usually they had some sort of infection 1 to 4 weeks prior. GI and GU infections are the most common. They can be HLA-B27 positive. And what that means is that if they are, typically they're a little bit harder to treat. We're thinking of young patients here who are more commonly associated with developing these sort of GI and GU infections, especially GU infections. Typically, you see a fair, distribution between men and women who develop like enteropathic or GI infections. When it comes to GU infections, men are much more common to get it than women, and that's because really it's just the STIs that we typically see in males, a little bit more common in males than in females. Prognosis is actually pretty good. Most patients don't even need to be treated. 30% do have recurrent episodes, and then the very small subsect, the ones who are usually HLA-B27 positive, do require some sort of immunosuppression. And how do we treat globally? How do we treat a lot of these seronegative diseases? A lot of them will require physical therapy, especially because they develop a lot of restrictive disease. NSAIDs are the initial treatment, and so you really can't go wrong with treating with systemic NSAIDs. If they don't respond to NSAIDs, you can send them to a rheumatologist, and we have a lot of medications that we use, a lot of biologics, TNFs, IL-17, IL-12, 23. If they have sacroiliitis, and that's the only symptom that they have, and they have nothing else, you could consider doing a corticosteroid injection to that area. If they have more peripheral arthritis, you could always send to us, and we could always consider adding, sulfasalazine or methotrexate, which is one of the disease-modifying anti-rheumatic drugs. From an exercise standpoint, flexibility training is super important. These are patients who are going to become progressively more restricted in their spinal movement. So thoracic extension exercises, hip flexion exercises, and a lot of core strengthening, especially in an extension-based way, really important. Because chest expansion can also be restricted, a lot of aerobic exercises are encouraged. Swimming is really great because it's very low impact on the spine. And really, we ask patients to avoid contact sports because of risk of fracture. Because it happens much earlier in their life, a lot of pediatric patients can kind of get away with it because they probably would not have developed this yet. This is usually more adults that you see who are like in older leagues. They may want to avoid some of these contact sports. Next one we're talking about is Maurice Cheeks. He was a point guard mostly for the 76ers, played for a few different teams between 78 and 93. He won an NBA championship for the Sixers in 83, 4-time NBA All-Star, 4-time first team all defense, and actually had his jersey retired for the Sixers. Head coach for the Blazers, the Trailblazers, the 76ers, and the Pistons. Currently the assistant coach for the Bulls. And what's important is that he was diagnosed with gout at age 46. I don't know if you guys remember. I remember seeing this when I was in college, that they were talking about on ESPN, where he was actually on the sideline coaching with his shoe off because he was actually having a gout flare at the time. And so what the problem with this is that this is a disorder of purine metabolism. It's characterized by high uric acid levels and deposition of these uric acid crystals in the joints and periarticular tissues. And if it's unopposed or if it's not treated, you can just develop recurrent swollen joints. And how do we kind of develop this? We can get it through our diet. We can get it we actually develop uric acid in our system as well. And the reason why we develop gout as humans is that we are missing an enzyme called uricase, which degrades uric acid to allantoin. Allantoin is completely soluble. Uric acid is not. And so because we're lacking this uricase enzyme, we can develop gout flares. So why do we develop too much uric acid in our system? Well, we can either overproduce it, either in our body, or we get it from our diet, like eating a lot of red meat, drinking a lot of alcohol. We can have a problem excreting it through the kidney, which is probably the more common reason. But usually it is a combination of both. I would say that 90% of gout patients are undertreated to some degree, but usually there is a component of, hey, they went to a wedding, they had a little bit of alcohol, they had the surf and turf, and they had their first gout flare. Men are much more likely to develop it than women, and that's, again, a lot of it is because men typically drink more alcohol and men typically eat more red meat in general. It's rare in women before menopause because estrogen is also very protective against gout. But once women hit menopause, their risk of gout kind of goes closer to 1-to-1 to men's. It gets worse as you get older. And if you have a lot of comorbidities like hypertension, diabetes, hyperlipidemia, these things can increase the risk of developing gout. Having chronic kidney disease and not being able to excrete that uric acid can also increase your risk. Organ transplant patients, their medications can increase the risk. Alcohol, soft drinks, all those things can increase your risk.
Hey, Ahmed,
Yes.
I have a quick question because you brought the estrogen thing up. If you treat women with transdermal estrogen, does that then decrease the risk for gout again during that perimenopausal and postmenopausal time period?
Potentially. The data is kind of weak on it, but I do have some patients who actually had gout, and they were, I think, like around 55. They had not been on any sort of hormone replacement therapy earlier in their postmenopausal state, developed gout, went on to be on hormone replacement, and then having developed gout since. So probably is the answer. There's a good chance that if you do transdermally, I'm not sure if this patient was given transdermal estrogen. I imagine it should also help. But that's a really good question.
Thanks.
4 stages of gout. Asymptomatic hyperuricemia. These are patients who are just their uric acid is just climbing and they don't even know it. Then they develop a flare. Then the flare kind of goes away, and they're in this intercritical gout period where their flare went away, but their uric acid continues to climb, and eventually you can actually develop a chronic like tophus in that area. Typically very acute, usually monoarticular, very swollen, very exquisitely tender. This is some of the worst pain that some patients feel. I always think about, from one of my room textbooks, there was always a quote on every chapter to start, and I don't remember any of those quotes except for the one on gout. And it was anonymous U.S. veteran who once said something along the lines of, I've been shot, I've been stabbed, and I've been nearly drowned, and the worst thing that ever happened to me was a gout flare. These are patients who can develop it in the joint, but also can develop it in non-articular areas like the bursa. The most common area to develop it is in the first MTP of the toe. They usually do resolve on their own, but the problem is if you don't treat it and it does go away on its own, they become more frequent. They can start developing other joints, and each flare can last a little bit longer. And eventually, you can develop this tophus. And I'll show you a few pictures of tophi. They're not pretty. So how do you diagnose? The uric acid itself is not diagnostic. You can have a high uric acid but still not develop gout, though that is not uncommon. You can check X-rays, ultrasound, dual energy CT. Synovial fluid will actually give you the diagnosis because you'll actually be able to see the crystals in there. And same with histology, if someone had surgery on an area and they were able to see uric acid crystals on there. And then if you see clinical evidence of tophus, that gives you your diagnosis as well. So taking a look at some tophaceous gout here, these are some of the patients that I've seen in the clinic. And as you can see, these are patients with long-standing gout that was never truly treated. And as you can see, they developed this tophaceous burden that have actually caused a little bit of a mass effect in their joint. And if this goes on long enough, eventually it can rupture, and this becomes really, really high risk for infection, not just cutaneously, but it can develop a tract to the bone, and you can develop osteomyelitis. So these, if you see a patient with an open tophaceous presentation, send them right to the emergency room. They need IV antibiotics. Typically, if you were to squeeze this out, it would come out like almost like cottage cheese. Now, this is the worst case of gout that I've ever seen. This is a guy who really just never got treated for it, developed worsening tophaceous burden, and eventually got to the point where he couldn't even use his hands. He is a patient who has a lot of other mental health and socioeconomic issues that stop him from getting the care that he needs. But this is as bad as it probably can get. And if you were if you were to take a look at X-rays, you can start to see erosive bony deformities along a lot of these joints here too. Okay, here as well. But this is a man who really can't use his hands anymore because of his gout. When taking a look at it from an ultrasonic perspective, typically what we see is what we call a double contour sign, which is the monosodium urate actually lines the joint itself. And so you can see a little bit of joints or a little bit of swelling around the joint itself, and that could tell you that there's some gout there. But if you look here along the joint, you can almost see this band of uric acid right above it here, and that is also diagnostic of gout. If you were to do a dual energy CT, you could also find as well. What a dual energy CT does is it kind of takes every composition of like bone and different things like calcium, uric acid, it labels them with a different color, and you'll be able to actually assess the burden that they have if you're not able to clinically see it either on X-ray or an MRI. When you do a synovial tap, typically you'll be able to actually see these crystals. They're usually yellow, they're needle shaped. When it's parallel to the axis of the red compensator, it's usually yellow. When it's perpendicular, it is blue. That's more of like a board question for your primary care boards. If you see that the crystal is inside a cell, that means it tells me that the cell is trying to eat it. And that tells us that there's probably an acute flare. If it's extracellular, it could tell us that they just happen to have crystals in the area. They've had flares in the past. When we check the fluid, typically inflammatory, 20 to 50,000 leukocytes, neutrophil predominant. And this is what it typically looks like under a microscope. This is a little bit of a grainy picture. And as you can see, if you were to say that it was parallel horizontally here, that this would be yellow needle-shaped horizontally and kind of blue needle-shaped perpendicular. This is a patient that I took out some fluid not too long ago, and this gives you a pretty good representation of that needle-shaped fiber, both in the perpendicular and parallel views. From a management perspective, typically we do lifestyle recommendations. You can treat flares, you can do urate lowering therapy and prophylaxis, starting with like kind of lifestyle modifications. Weight loss is encouraged. Heavier patients typically develop gout more. Avoidance of alcohol, or at least cutting down on alcohol. Of all these things, beer is the worst offender. It has the highest purine load, then wine, then liquor. Sugary drinks have a high purine load as well. And same with red meat and seafood. We encourage regular exercise. And we do sometimes a medication reconciliation, because a lot of the medications that are given to older patients can induce gout flares, like a lot of diuretics. Treating an acute flare, typically you really can't go wrong. You should be able to, in your practice, still be able to treat an acute flare with NSAIDs, colchicine, or steroids. And you can kind of choose whichever one you feel the most comfortable using. I think steroid probably works the fastest. Colchicine probably works the slowest, but of the three, long-term, probably colchicine is the safest. Problem with colchicine is that patients can't tolerate it because they get a lot of GI upset from it. NSAIDs, you got to be careful with developing gastric ulcers or chronic kidney disease. And then systemic steroids, if they're diabetic or if they're high risk for infection, you have to be worried about that. If they have contraindications to all of these things, which we can sometimes see, typically think of like a horribly controlled diabetic with chronic kidney disease and heart disease and can't tolerate colchicine, then you can send to us and we can give them a different medication like anakinra, which also works pretty well. But the long-term thing for these patients is to make sure that the uric acid is low so that they don't keep getting these flares. And what we do is if a patient has a certain few indications, we typically start them on urate lowering therapy. If they're getting more than like 1 or 2 attacks a year, we typically start it. If the uric acid is very high, above 9, if they have like uric acid stones in their kidneys, If they have tophi, clinical tophi, or if they have kidney disease stage 2 or worse, we typically start urolithium therapy. And the goal is to try to get them under 6 in classic gout, or if they have tophi, we try to get them under 5. And the medications that we use, typically allopurinol, you're probably not going to use a whole lot more than that. If you're practicing primary care on top of sports medicine, you may use some of these medications, but typically allopurinol, febuxostat, probenecid, these are medications that you use in the outpatient. For the patients who are absolutely not responding to any of these medications, in rheumatology, we'll give a pegylated uricase or a synthetic uricase enzyme, which is essentially going to convert all that uric acid to allantoin. Problem is that it is an infusion. You got to give it every 2 weeks. Very cumbersome. Patients really don't like it. And then from a prophylaxis standpoint, whenever you're treating these patients with uric acid lowering therapies, you should have something in the background to prevent them from flaring up. So even if they're not flaring up, if they're past the flare stage, you might want to have even just like a low dose NSAID, colchicine, or steroid in the background. And usually you keep this for about 6 months until they're well controlled, and then you can discontinue it. Pseudogout is another thing that we typically see a lot of, and it can get confused with gout pretty frequently. The difference is that instead of uric acid, you see calcium pyrophosphate crystals. They're typically rhomboid and positively birefringent on the synovial fluid. Typically, these flares are less painful, but they take longer to get to their maximal peak, and they typically take a lot longer to also self-resolve on their own. You can see a lot of chondrocalcinosis on the x-rays. The big toe is usually not involved like it is in gout, and there's no need for urate-lowering therapy or any prophylaxis. Usually, you just treat the flare and it goes away. Patients who are typically older, patients who have a lot of osteoarthritis, mechanical joint trauma, meniscectomies, those are the most common. Those are the patients who will most commonly get this. From a genetic perspective, if you get this really early in your life, there usually is a genetic component to it, and usually there's spinal involvement, though you probably won't see this too much in your practice. What's kind of strange is that sex and obesity are not risk factors for developing pseudogout the same way they are in gout. And if you take a look at a couple X-rays, you can actually see some calcium deposition here along the meniscus and along the TFCC here, and if that kind of gets red hot swollen in that area, that tells you there's a bit of a pseudogout flare. And taking a look at it here, this is a patient who developed diffuse hand swelling. We drained his wrist, and we were able to find a small calcium crystal. It's a little hard to see, so we brought a little bit closer here. And as you can see, intracellular, it's actively being attacked here. And so this tells us that there's an acute pseudogout flare. As we're starting to kind of to wrap up a few of these last few rheumatic diseases, just want to touch base on them because I think they're important in clinical practice, and you'll probably see them on your boards to some degree. Next one we'll talk about is Shannon Box. She's an NCAA, she's a midfielder, NCAA champ, 95 from Notre Dame. She's a 3-time gold medalist for the U.S. Women's National Team in 04, 08, and 2012. She was a FIFA World Player of the Year finalist in 2005. And she actually was diagnosed with lupus at age 30. We're not going to spend a whole lot of time on lupus. I mean, there are whole conferences, not just lectures, the whole conference is dedicated to lupus because of just how many different manifestations that you can develop. If you have 2 twins with lupus, they may have completely different pictures because this can infiltrate any disease, any organ system. You can have cardiac involvement, you can have cutaneous involvement, you can have arthritic involvement. And so, I think the most important things here is to recognize that it's much more common in women than it is in men. It is quite rare, only about 0.1% of the population, but there is a very strong disparity between the types of people who get it. Black females are probably the highest risk of developing lupus compared to, let's say, a white male, 40-time risk. And then women in general almost have a 10-to-1 risk of developing lupus versus men. And again, it's not really clear why that's the case. A lot of the clinical features, you can develop that typical malar butterfly rash, a lot of oral nasal ulcers, very photosensitive skin, almost like developing sun poison, just being outside for a few minutes. You can have hair loss, you can develop Raynaud's, which is basically the hands upon cold exposure, the fingers turn ghost white in the cold, they become blue, and then as it starts to rewarm, they become bright red and very irritated. You can develop arthritis, you can develop pericardial effusions, pleural effusions, hemolytic anemia, proteinuria, cytopenias. Like the list goes on and on with lupus. And some of the just important serologies that you'll see, you can have a positive ANA. Anything greater than 1 to 80 is typically considered positive. Double-stranded DNA, Smith, SSA, SSP, antiphospholipid syndrome, antiphospholipid antibodies. And this is what the typical lupus rash looks like. And as you can see, it kind of spares the nasolabial hold, but it kind of encompasses, it goes over the nasal bridge and does look somewhat like a butterfly. And this is Raynaud's here upon cold exposure. It almost like clearly looks demarcated here. And as this gets a little bit warmer, this will turn a little bit blue and then very, very bright red. This is important in patients who play sports outside, especially like in the fall or in the spring, who may have difficulties maneuvering and doing fine motor movements. So something to think about. The treatments, really the only treatment you're going to use in these patients from a sports medicine perspective is prednisone. We have a litany of other medications that we do use, and actually missing on here is benlysta, which is a newer medication, but typically prednisone is the one you're going to use. From an exercise perspective, we really want to protect against sun exposure. So those who develop that sort of sun poison, you have to be careful. So typically if they can tolerate the sun, great. If they can't, they may have to do an indoor sport. Hand warming for Raynaud's, because these patients can develop pleural and pericardial effusions, getting a baseline echo for those who are going to participate in moderate to high intensity exercises is recommended. Avoid exercise when they're actually having a flare. From a primary perspective, they may want to get a urinalysis regularly to make sure that there's no renal involvement. And then know that if they do get injured or they have surgery, they can trigger their lupus as well. And then just very briefly, this is Venus Williams, who is a known advocate for the treatment of Sjogren's. The most common symptoms are typically dry eye, dry mouth, fatigue. Typically, we treat Sjogren's symptomatically. So a lot of eye drops, make sure that they're adequately hydrated, making sure that they get proper dental care. And then you usually send them to a rheumatologist. We can do more objective testing like a Schirmer's test, which measures the actual how much tear production they're producing. And sometimes we'll even get a salivary gland biopsy, which will give us a diagnosis. But typically, you don't need any immunosuppression. You don't need to put them on steroids and NSAIDs. Usually just treat symptomatically. And then polymyalgia rheumatica, the reason why I included this is that they will allegedly put this on your boards. Like allegedly, I may have had a question where they asked me, allegedly, a question, an elderly patient who developed bilateral shoulder and hip girdle pain or weakness, really high inflammatory markers, and then allegedly they might ask you what dose of prednisone to give, and the answer to that question would be giving about 15 to 20 milligrams of low dose prednisone with a very, very robust response. The reason why this is important is that these are patients who are going to be on steroid therapy for a really, really long time. Typically, the major problem with primary care and some other physicians who treat this is that they put them on a prednisone taper for like a week or two. These are patients who need to be tapered very, very slowly over like on a monthly basis, and sometimes this can take over a year to get them off of prednisone completely. So that increases the risk of developing osteoporosis. So if you're concerned about polymyalgia rheumatica, what I recommend is putting them anywhere between 15 and 20 milligrams of prednisone and then taking them to a rheumatologist and keeping them on that dose until they're seen by us. If you wean them off too quickly, their symptoms are probably going to rebound. Just want to take a minute to talk about therapeutic use exemption. From a rheumatologic standpoint, all of our medications can be used. They're all permitted. There really is no ban or anything. Corticosteroids are the only thing that you need a therapeutic use exemption for. If you're taking it orally, which we typically would be in patients who are flaring up, that's not a problem. We can always write a letter and make sure they are able to continue to compete. If they're getting topical or intra-articular, you can usually do an abbreviated TUE, meaning that once you submit the letter, it's valid from the moment you submit it. It doesn't have to go through a review process. Versus if you do like an oral prednisone, oral corticosteroid, you have to usually get it approved. For all of our DMARDs though, like methotrexate and all the biologic therapies, you don't need to get any permission to use them. From an osteoporosis standpoint, you can use any of those medications without a problem. There are newer medications that are anabolic, like Forteo and Tymlos. Those are medications that are banned. There is an anabolic component to them, okay? And then just quickly, last thing I want to talk about is just vaccinations, because we live in a COVID world, and these are medications that we typically give in rheumatology that are very immunosuppressive. Typically, you can continue most of our medications without a problem. For flu, we just have people hold their methotrexate for about 2 weeks after the vaccine. And for other non-live attenuated vaccines like the COVID vaccine, for all of our diseases, we really just continue them. And sometimes we'll play around with the timing, but really no contraindication to giving these vaccines in these patients. If someone's on prednisone, you can continue. If you're giving the flu vaccine, it doesn't matter what dose of prednisone they're on, you can give them the flu vaccine. If for other non-live attenuated vaccines, again, think about COVID vaccine, you can give it as long as they're on 20 milligrams or less. Excuse me, less than 20 milligrams. If they're on 20 milligrams or more, we do worry about the efficacy of the vaccine. And so we wait until their prednisone dose is tapered to a lower dose before we do that. Now, again, these are conditional recommendations. So if you feel like the patient really needs it, you can still give it. And then for like live attenuated vaccines, we do usually have to stop the time. We usually have to stop the medications that we give either before or after or both. But again, have a rheumatologist kind of worry about that. So before their first rheumatic appointment, I think the thing to kind of take away from this presentation, some labs to get basic labs, CBC, CMP, get inflammatory markers, ESR, CRP, you get a rheumatoid factor, CCP, ANA. I usually, plus or minus getting a hepatitis panel or an IGRA or tuberculosis testing. Sometimes it just saves us a little bit of time because if they do need to be put on treatment, we need to make sure they don't have a chronic indolent infection that can be reactivated. And then from a sports perspective, NSAIDs and prednisone, you really can't go wrong. When it comes to some of the more complicated medications that we give, those are best served to be given by a rheumatologist. But a lot of times NSAIDs or prednisone are fairly safe. Just see which one you're more comfortable with. And then make sure that you do some imaging other joints so that way we know what we're dealing with. These are some of my references. And then you guys have any questions? This would have been a lot better if the Eagles had won the Super Bowl. But
Hey, Ahmed, great talk. Thanks for the overview. I just texted you my family photo from pre-pandemic with my children standing with Shannon Box.
that's awesome.
Yeah.
That's
Mandy,
awesome.
Mandy and I, well, I think we worked with her back when she was doing U.S. Women's National Team stuff, but I saw her at a Columbus Crew game many years ago.
That's awesome.
My one question actually has to do with vaccines from some of your last slides. Have you seen anybody, oh, you don't even need to flash back. It's more a COVID vaccination question. I had maybe 2 or 3 kids who I saw post-COVID vaccine who came in for random unilateral knee effusions. And it's one of those things. It's like, well, is it related to the vaccine? Is it not related? They were all happening within 3 to 4 weeks of having the vaccination. They had never had injury. They had never had an effusion before. They got sent to rheumatology, got worked up, and like nothing ever came of it. Have you seen many people associated with the vaccinations getting joint effusions at all, or is that a random?
Typically, I have seen it a few times. I've actually seen it post-COVID or post-COVID vaccine. And I've seen it in both cases. When I see more post-COVID, I think of more like that reactive arthritis. Usually a few weeks after developing COVID, they'll go on to developing this kind of lingering joint pain or effusion. Typically, the further away they get from that COVID infection, typically the better they get. But I do have a couple of patients that I've had to give steroids to in the short term to get them through it. There are some patients who have developed almost like an exaggerated immune response to these COVID vaccines as well. And so what will happen, and I think it's still a little early to tell, but sometimes you can almost unmask a rheumatic disease in these patients by kind of stimulating the immune system a little bit earlier with any sort of vaccine. So I have seen it. The few times that I've had like a knee effusion, when I've drained it, it typically looks normal. Like there's no inflammation in there. And so I've treated it almost as like a mechanical osteoarthritis. But I would recommend even just a short course of steroid if they can, or NSAID to kind of bring it down. And then it's a little bit harder in PEDS patients because a lot of the PEDS patients, unless they're developing JIA, are usually too young to develop a lot of the rheumatic conditions that we see for it to flare. And so they may go on to develop an autoimmune condition in the future. We know that like if someone had flu or parvovirus when they were a kid, they can go on to develop an autoimmune condition in the future. COVID is just too early to tell if it's going to increase the risk. And the vaccine, again, I think a little too early to tell, but yes, I have seen it. And typically I just give supportive care and treat symptomatically until it goes away. And in the few cases that I've seen, they've gotten better over time, the further away they got from the vaccine. And then I kind of recommend that they don't get the next vaccine, they don't get the next booster for that patient. They just have to just be a little bit more vigilant about who they're around.
Awesome, thanks. Anybody else have any questions for Ahmed?
Thank you, Ahmed.
Thanmead. Ahmed.
No
Thanks,
problem. My
Ahmed.
pleasure.
My house would have been better if the Bengals had won the Super Bowl, but
Oh, yeah.
that's okay.
Yeah, I mean, oh man, I was really